change between the 7 and the 17%. And the kyphosis negatively impacts the lung vital capacity and bowel transit, quality of life, self-sufficiency, and mood, and ultimately resulting in significant decrease in life expectancy. What's the vertebroplasty indication? As you know, it's osteoporotic fractures or oncologic fractures like metastasis or hematopoietic or lymphoid neoplasm, or vertebral hemangiomas and painful small nodules, with no responded to conservative treatment, of course. The first vertebroplasty was made in 1984, and the successful rate reached to 19% and 4.5 average point decrease in VAS. There are some contraindications, absolute and relative contraindications. The absolute contraindications contains infection or pre-existing epidural extension of metastatic tumor with encroachment on neural structures, uncorrected bleeding diathesis, severe canal compression, and reaction to cement. And the relative contraindications are severe collapse of a vertebral body. We can prefer the kyphoplasty in such these patients, or posterior wall disintegrity. But there is some debate about posterior wall disintegrity. Some studies revealed that the posterior wall disintegrity must be excluded from the relative contraindications. And Nakano et al. Studies on 40 patients with osteoporotic burst fracture, the posterior leakage was found in 10% and without any clinical sign. And also and et al. Published a new paper about this issue. 20 patients with burst fracture after the vertebroplasty cement leakage was revealed only in one patient without any neurological findings. And the other relative contraindications are oncologic patients with severe canal compression, and some paper released by Sun et al. On 43 patients with spinal metastasis with epidural encroachment. On 40 of them have neurologic deficits, and cement leakage was obtained 69%, but there is no any clinical signs. And we need to discuss the relative contraindications again. And there is several insertion technique. We can group it in the extrapedicular and transpedicular approach. When we use the transpedicular, or what are the advantages or the disadvantages of this approach? The advantage of the transpedicular approach are you can, the root is only in bone hole, and you can protect the vascular and neural structures, but with the transpedicular approach, to reach across the midline is more difficult, and the risk of the dural tear or cord injury is higher. But in extrapedicular approach, we can use it with the inadequate pedicle with patients, or we can reach across the midline easily than the transpedicular approach. And what are the complications? As you know, the complication rates are between 1 and 5. The most seen complications are adjacent fracture, and there is some a new paper about interesting complication, the split fracture. It published by the Sassani et al. And they dealt with the split fracture after the kyphoplasty. If you didn't feel all the vertebra, you can face with the you may face with this problem later. Let's look briefly to kyphoplasty 2. First kyphoplasty was made on 1998, and it gives opportunity to correction of the vertebral height or correction of the kyphotic deformity. When we compare the vertebroplasty and kyphoplasty, vertebroplasties are easier as a short duration surgery and cheaper and lower radiation exposure, but the kyphoplasty has a lot of advantages, like correction of kyphosis or correction of vertebral height, better cement distribution, lower cement leakage risk, safer and lower complication rates. Let's look some studies. In Ma et al. Study, they found the kyphoplasty have more advantage in terms of the kyphotic angulation correction when the fracture in posterior, or if there is a obvious height loss, and if it's have an advantage about the prevention of the cement leakage and to correct the anterior height. And there are no any differences in terms of the VAS, ODI, and adjacent segment fracture. And the vertebroplasty has an advantage only about the operation duration. There are a lot of studies to compare the vertebroplasty and kyphoplasty, and all of the studies have a nearly same results. So, when we need to use the vertebroplasty, is the fracture is acute, and if there is no any severe compression or kyphotic angulation, and if the patient has a high morbidity, we need to use the vertebroplasty instead of the kyphoplasty. And what about the filling amount? The Lipschner et al. Claimed that in their biomechanics study, only a small amount of the bone cement was necessary to restore the stiffness of the damaged vertebral body to the bread damaged value. And in the other study, they found a relation between the cement distribution and pain. Roeder claimed that the cement volume is the most important modifiable predictor for pain relief in bilateral kyphoplasty, and the volume should be more than 4.5 milliliters. Belkov, like a summary of all of these studies, they suggest that the 2 milliliter is enough for biomechanically, and 4 to 6 milliliter better for the clinical result. And how to feel? The Zhang et al. Published a new paper about this, and they found that the recompression risk on the same vertebra is lower if you feel the vertebra from up to level to lower. It's only 8%. But if you feel the vertebra only over the lower end plate, it will be raised to 42%, the refracture risk. As you know, the kyphoplasty traditionally defined as bilateral approach, but you know, some paper released about the unilateral approach. What are the advantages of the unilateral approach? It has a short operation duration, lower radiation exposure, lower complication risk, and lower cement leakage risk. Let's look some papers about this issue. Yang et al. In their meta-analysis, they didn't find any significant difference between the unilateral and bilateral approach in terms of the kyphotic correction on vertebra height, or the VAS ODI SF36, but they didn't look to operation duration and the radiation exposure. In our study, we didn't find any statistical difference in terms of the kyphotic correction, VAS ODI, but we found statistical differences in terms of the operation duration and the used cement amount. There are some paper in same issue, and all of the result of these studies are similar. So, when we need to use the bilateral approach, Chen published a paper about the unilateral approach has a biomechanical imbalance risk, and Steinman claimed that bilateral approach is necessary only when the cement is accumulated unilateral. And the Yang claimed and published a criteria about this. Is the surgeon has a low experience? Is the vertebra height has a very severe height loss? And the relatively healthy bone mineral structure, you need to use the bilateral approach. So, if we use a unilateral questions, we need to use a transpedicular or extrapedicular approach. or should the cannula directed to the midline? If there is a severe compression, we can use the unilateral approach, or bilateral filling can be achieved by unilateral approach. Let's look these questions with one case. As you've seen, there is a severe loss on vertebral height. Under fluoroscopic guidance, unilateral kyphoplasty was made. As you see, the approach is transpedicular, so the needle didn't cross the midline, but as you see, we achieved two bilateral filling. The postoperative CT images. As you see, the transpedicular approach, unilateral only, and the bilateral filling. But we cannot achieve such this filling every time. To fill bilateral easily via unilateral approach, we need to use extrapedicular approach, and we need to direct the needle across the midline. And last two things about the knee fracture. It's knee fracture found after the vertebroplasty and kyphoplasty between 11 and 52%. Is it related by vertebroplasty or kyphoplasty, stiffness, cement amount, cement leakage to the intradiscal area? Sangatol published a new paper, meta-analysis of the 13 papers. They claimed that there is no significant differences in terms of knee fracture developments between the vertebroplasty, kyphoplasty, and conservative treated patients. And the last thing, what about the biopsy? Mukherjee et al. Published a paper. Patients who haven't any malignity history or suspect, they found a 4.7% malignancy after the biopsy. Thank you.
Thank you, Dr. Yılmaz. Any question to Dr. Yılmaz about vertebroplasty or kyphoplasty?
In general, do you use kyphoplasty? You prefer yourself?
Yeah,
or vertebroplasty?
No, I'm preferring kyphoplasty and unilateral approach.